everyone, and welcome to the Healthy Living Show. I'm Sandra Smith. I'm the Chief Strategy Officer for Hilton Head Regional Healthcare, and I'm actually substituting for Debbie Lyons today. Debbie's out celebrating the birth of a new grandbaby, so we're very happy for Debbie and her family, and really happy for you to welcome a new life into the world. Today we're here with Dr. Madeline Russell. Dr. Russell is a board-certified gastroenterologist, and the reason that we're here is because March is Colorectal Cancer Awareness Month. Now, Dr. Russell, one of the things I learned as getting ready to talk to you today is that colorectal cancer is actually the third most common diagnosed cancer in the United States with men and women, and actually the second cause of cancer-related death. So it's definitely something we want to educate ourselves about and learn a little bit more about how we can take steps to improve our health. But before we do that, tell us a little bit about yourself. Tell us about your experience and your training.
Absolutely. My name is Madeline Russell. I'm a board-certified gastroenterologist. I've been in this area for almost 2 years. It'll be 2 years in September. I came from Charlotte, where I finished up my fellowship training. I actually am familiar with the area. I did my residency down in Savannah, Georgia with Mercer at Memorial Medical Center, and then met the group that I work with when I was training there, and came up here after I finished training.
So you're here working in our community full-time?
Correct. I'm in Hardyville full-time.
Okay, great. So when you see, I imagine you see a lot of people who are concerned about colorectal cancer or maybe want to get screened. Tell us just the basics. How does colorectal cancer start? What is it?
Well, colorectal cancer starts as a mutation, and there can be germline mutations, but the bottom line is that there's mutations in the mucosal lining of the colon, and then that develops into a cancerous growth, precancerous to cancerous growth, and ultimately that develops into the tumor that can spread to other parts of the body or can stay isolated to the colon.
Okay, so let's back up just a little bit. So when you say the mucosal lining, so our colon has a lining in it that sort of protects. Well, tell us a little bit about the mucosal lining.
Absolutely.
So we understand.
The colon is a luminal organ. It's an open, hollow organ, and there are lining layers of the colon. And the initial layer, which is what we examine on the colonoscopy, is the mucosal layer, which is the layer that is the outermost layer or the internalmost layer of the colon.
Okay. Okay.
That's what we examine during the colonoscopy.
Okay. So if people, if you're concerned that you may have colon cancer, what are some of the symptoms or signs and symptoms that folks might experience?
Signs and symptoms can vary. One of the most common signs is weight loss and a change in bowel habits. Change in bowel habits meaning your normal regular pattern of bowels is all of a sudden becoming looser or changing to less frequent. A change in color, consistency of the stool, and iron deficiency anemia is a common one that primary care providers pick up on when doing routine labs, CBCs and things like that, making sure that the iron levels are up. If a patient presents with a drop in their hemoglobin and anemia, and it is in fact iron deficient, then the next obvious step in the workup would be to do a colonoscopy to rule out GI malignancy.
Okay. Are there folks that are more likely to get colorectal cancer at a certain age, a certain race, or?
Well, we start screening typically around age 50. Some of the national organizations have changed to age 45. The American Cancer Society recommends that colorectal cancer screening begin at age 45. But for most people, we start at age 50. Races that are perhaps a little more likely to develop the cancer earlier would include African American ethnicities, Ashkenazi Jew populations as well. Those recommendations are pretty solid at starting at age 45 for screening for colorectal cancer. Moreover, people that have family members, first-degree relatives, mother, father, sister, brother, who have had cancer, the recommendation is to get screened 10 years younger than when they presented with the colorectal cancer. So if you had a brother or your father or mother develop cancer at age 45, you'd actually begin screening at 35.
Okay, does that mean is colorectal cancer genetic then? Are we automatically predisposed to get it?
There are risk factors that are environmental, and there are genetic risk factors.
Okay. What are some of the things that we can do to help us not have the propensity to get colorectal
Absolutely.
cancer?
Well, obviously there's no modification you can do to the genetic component, but as far as the environmental components go, a healthy lifestyle, avoiding alcohol, avoiding smoking. There's some debate about nitritized meats and red meats, avoiding those. Exercise is very important. and overall a healthy lifestyle in general.
Okay, so, and those are a lot of things that really play into helping us avoid cancer in general, not just colorectal cancer.
Absolutely.
Okay. When someone comes in for, well, let's back up just a minute. There's a very common question that our viewers have, and that is, what about those home screening tests? The tests that we can do in the privacy of our home, are those the same thing, or should we do that in place of colonoscopy? Or tell us a little bit.
The gold standard for colon cancer screening is in fact the colonoscopy. It's the only screening test that we have that actually reduces the likelihood of developing colon cancer because we remove precancerous lesions. That being said, at the end of the day, physicians want patients to get screened by any means necessary. There are certain people who don't qualify for the home screening, and those would be what we deem as high-risk individuals, people who have had polyps in the past, who have certain signs and symptoms, inflammatory bowel disease, and people with family members that have had colorectal cancer. Those people would be excluded from those home testing. But for all comers, the home testing is not a bad idea. But again, the gold standard would be to have the colonoscopy. Those home testings, they're commonly seen in commercials on TV, do allow for stool analysis, but they only tell you are cancer cells present or not present. They don't prevent the development of them in the future. They don't tell you if you have polyps or things that could lead to cancer by the time you're ready for the next test. Okay, so when you do the test at home, is it actually looking for cancer cells, or is it looking for blood in the stool? There are quite a few different types. There's immunohistochemical stains that do check for cancer-style cells, and then there's tests that check for blood, occult blood that we don't see with the visible eye.
So it sounds like what you're saying is, if you do the test at home, you're sort of learning what's there, but you're missing out on the part that you would look for in the colonoscopy, where you're checking that lining and also perhaps have the opportunity to remove anything that looks dangerous.
Correct.
Okay, so kind of segueing into that, give us a little bit more explanation about what you're actually looking for when you do a colonoscopy that would be different from the home test.
When we're doing a screening colonoscopy, we're again visualizing the mucosal lining of the colon. We go from the rectum all the way to the cecum, which is the end of the colon, and we carefully evaluate the lining to see if there's any small polyp growth. And we're talking things can be as small as 1 to 2 millimeters in size that can, in a certain period of time, turn into cancer. So our job is to carefully find those and remove them so that we eliminate the risk of those growing into cancer in the future.
So when you have the colonoscopy done, if you see that, would that be like what people call a polyp? Is that something you can take out right then?
Yes, typically we can take those out right then, with a few exceptions if the patient's on blood thinners, etc. But the whole idea of the colonoscopy is to remove any of those lesions if we find them.
Okay, so we have a couple of things here that you might be able to demonstrate for us to show us a little bit about how you are looking at the colon when you do the colonoscopy. I know that that's something that people dread, and they think, how can I avoid this? But ultimately, you got to do it. Right,
yes,
to get
absolutely, to get screened.
Yeah.
The worst part about the colonoscopy, most patients say, is the colon prep, which is a laxative that you have to take to clean out your bowel, so we can have adequate visualization of the colon. And I'd like to add that if you do a home screening test and it becomes positive, you miss out on the screening colonoscopy, and that actually changes to a diagnostic colonoscopy, which can pose problems with insurances occasionally.
Okay.
But going back to the prep, I have to step back again. Most people want to avoid the prep, hence that's why they do the home test.
Okay.
But going to the prep, it's a laxative that cleans out your bowels. You do it the day before. You do have to do a clear liquid diet the day before as well to make sure that things are adequately cleaned and the prep does its job. But then you come into the hospital, you get an IV stick, we get you all set up, and you'll come to a suite like this, which is an endoscopy suite, and we perform the colonoscopy. We actually have a colonoscope here. It's not completely hooked up, but for visualization purposes, I think it will do the trick. This is a standard colonoscope, an adult colonoscope. It is a very flexible, movable piece of equipment, and this is the end that the endoscopist would hold that would control the up, down, side to side motions of the colonoscope. And I will add that this is much smaller than the girth of the colon. And what we would do is we would insert the device in through the rectum and go through the colon using the hand controls to navigate around and see portions of the colon. And if I turn this off here, you can see that there's channels here where we can take instruments and put them in there and remove the polyps.
So that's both a camera and an instrument.
Correct. Well, we have instruments that go down through the device and come out through here, so we can remove.
Now, as you were doing that, I was noticing on the screen that we could see a little bit what you would see when the camera was going in. Could you?
Yeah, absolutely.
Could you reference?
I will add that my hand by no means represents a colon, but it would be evaluating. You can see how high definition that is, where you can see everything on my hand. But we would look through there, and if we saw anything like a polyp, we would simply take a device to remove it. But it's a cylindrical picture like that.
Okay. Now, how long does this take?
Colonoscopies typically take about 15 to 30 minutes, depending on the presentation of the patient. The worst part and the longest part by far is the prep. That's a whole evening thing, and takes a day out of their work life or their life where they don't go back into work the following day.
Okay. And when you're having the colonoscopy done, are you completely asleep? I mean, how do people experience any discomfort?
It's a great question. So that varies based off of the patient's overall medical health needs. We typically get an anesthesiologist involved, but sometimes the endoscopist will actually provide the sedation for the patient as well. The idea is for them to be in a twilight sleep where they're completely comfortable. They may remember some things, but they have a little bit of analgesia as well, where they don't recall, or amnesia rather, where they don't recall exactly what happened if they were to have a brief moment of lucidity during the procedure. Most people go complaint-free. There's a little gas pain afterwards, but for the most part, it's a very easy, straightforward, and tolerable procedure.
So it is true then that some people say that they have the colonoscopy and they don't remember anything. They just remember saying it's time to go to sleep and it's time to wake up.
That's very true. That often happens.
Good. Well, when we think about the importance of screening, it's so important to catch things early. But sometimes, people don't do it or things, for some reason things advance to the point that more care is going to be needed. If someone has colorectal cancer, what kinds of treatment are done at that point?
Once the diagnosis of colorectal cancer is made, or colon cancer, depending on the area that it's found in, we usually use a multidisciplinary approach where we have an oncologist, a surgeon if needed, a colorectal surgeon, and a whole team of providers that take care of the patient to make sure that every need is met and that we're treating them from all angles of the disease.
So that's a big deal. A lot of folks have to come together, different doctors, to take care of that type of issue.
It is a multidisciplinary approach for sure.
I asked that because you and I had a chance to talk recently about colorectal cancer on Hilton Head Regional Healthcare's Facebook page, Women's Wednesday. And I know one of the responses that we got from one of the viewers was how her mom, waited because she was really kind of embarrassed to talk about this and to get screened for some symptoms she had. And later, her mom apparently was advanced and she passed away. And that's something that really makes us all think about, again, the importance of just doing the thing we need to do, even though we dread it, and addressing the issue.
Absolutely. We all have colons. They all need to be screened. It is one of those less enjoyable things out of life, but at the end of the day, the prep is much less aggressive than, say, having colon cancer. Absolutely. So I know a lot of people have issues with the fact that it is a sensitive area, but at the end of the day, it is our job as professionals to go through and find it, and we just want to help our patients and make sure that they live long, happy, and healthy lives.
Indeed. Well, we're so glad you're here to do that.
Thank you so much.
Thank you for joining us. I really appreciate it. We've learned so much today about colorectal cancer and the importance of getting screened. Please stay tuned. We have some more information to come where we'll meet part of the team that's here during the process and learn a little bit more about the steps that patients experience at Coastal Carolina Hospital.